So this is the approach to the distal femur, and we are really bothered about fixing these fractures, not much about these things which most likely you can manage by either any of the routinely approaches which we have used. The hinge type joints do not allow mobility that well. Anteriorly you have a lot of important neurovascular structures, and posteriorly the most important triceps is there. So the elbow is sort of boxed in both sides by the soft tissues and by the peculiar arrangement of the bone. We need a good approach for a good end result. In the elbow, there should be a minimal soft tissue dissection. It should not compromise visualization. This is the most important of it, because when you are doing an intra-articular, you need a very good fixation, and the risk of heterotropic ossification and stiffness must also be decreased. We have lateral approaches, medial approaches, and posterior approaches. I am not talking about lateral or medial approaches because in the subsequent discussions there are faculty who are speaking about coronal shears, fractures, and other things. So I will be restricting myself only to posterior approaches. There is one anterior approach described which is mainly used for vascular repairs and other things in the supracondylar fractures. Now when you take the posterior approaches, you can broadly divide them into two things. One is the triceps on and another is the triceps off. That means any of the approaches which do not remove the triceps attachment from the olecranon, they are all put in one basket, triceps on. The rest are triceps off. If you take the whole thing is preserved, then you have the Alonso-Lamb's bilateral paratricipital approach. You have Studer lateral paraolecranon. If you split the triceps fascia, this is our older one, Campbell straight split. You have the Sahane and Stanley where you have the medial 1/4 split from the lateral 3/4. There is another approach which splits it at lateral 1/4 and medial. All these are semantic. If you take a tongue, again we have the old Campbell tongue with the distal base, or the Van Gorder which is inverted base. This is used in certain places. So these are all the triceps on approaches where the triceps is not entirely detached from the olecranon. When you go to the triceps off, this is what is mostly going to give you a very, very good exposure of the distal humerus articular surface. Here you have two things. One is the approach which deals with the osteotomy of the bone, and another is what elevates it off the olecranon surface. You have the Bryan Mori and the O'Driscoll trap approach, triceps reflecting and anconeus pedicle approach. Here you have the osteotomy, which is again into intra and extra-articular osteotomies. We will have to concentrate more on these things. Now, the patient position, like our previous speakers was saying, for anteromedial approaches, supine is the best. For if you want to access the distal humerus articular surface, you need a prone position or a lateral decubitus. The incision should be curved a little bit lateral because you don't want a scar on the resting area of the elbow. Also, the posterior approach has the least risk of cutaneous injury, and you don't get any painful neuromas there. This cadaveric study, and there are others which follow it, has shown that the visualized area following an olecranon osteotomy is maximum in the osteotomy group. The triceps reflecting approaches are next in the line, and the triceps split approaches are way down. If you take this is the from that pattern. You can visualize all this by the osteotomy group, whereas you can visualize only this much in this. But when you flex the elbow more, you can even visualize this. So this amount of visualization you can get in the osteotomy group. The triceps reflecting anconeus pedicle and the Bryan Mori are also comparable by later the past few years papers. They say like a few people say that the chevron osteotomy is not as is significantly better. I mean, it's mentioned in the last few years papers that Bryan and Mori and the trap approaches are better, but they also in their discussion accept that the olecranon osteotomy is superior. Let's see the disadvantages of both these people. The disadvantages of osteotomy is there is a risk of delayed or non-union, metal irritation, and probable need for metal work. This is not suitable for total elbow arthroplasty or interposition arthroplasty. If you think that you may not be able to fix that comminuted intra-articular fracture and you may have to go for something, please do not choose the osteotomy approach. Soft tissue approaches, the weakness is again the same. Triceps weakness, you can have partial avulsions and delayed tendon to bone healing, more soft tissue dissection. You cannot mobilize the elbow early. So you are caught between a rock and a deep area again. So you have to make your plan before surgery very clear. These are all examples. This is the Van Gorder VY tongue. This is the Campbell paratricipital alonsorums, where the entire thing is kept straight, and you work on these two windows. This is a trap where the unconeus is measured. Bryan and Mori, where it is entirely released as a this thing. These two are used nowadays. This is a little bit more used nowadays. But when you come to osteotomies, you have extra-articular osteotomies and intra-articular osteotomies. Extra-articular osteotomies have mostly been given up now. This is the step cut, what is, I forgot it, olecranon osteotomy, yeah, step cut olecranon osteotomy. And this is a Muller type, which I have not been using it. Most commonly, we have been using this olecranon osteotomy intra-articular. There are two types, and we are mostly into the chevron type. There is a modification of the olecranon osteotomy, which is by Mayo, because he has found, like, when you do the chevron osteotomy, the unconeus muscle is denervated or lifted off, and that can cause problems and a little bit of PLRI also later. So that is why they are now advising you to take the chevron along with a small bit of the unconeus, something like a trap approach. So the healing is much better. 2 or 3 important points I'll tell you about the chevron osteotomy. You should always try to exit in the bare area. Please do not go too distal, please do not go too proximal. This is to illustrate the bare area. And where the approach is recommended is, if you come more into C1, C2, C3 types, olecranon osteotomy is measured. If you are in the metaphyseal area, you can go to any of the triceps on methods. If you are planning for any of the arthroplasty or interpositions, please do not ever plan for osteotomy approaches. And post-osteotomy fixation is what people tell wrongly about, and you can do by a lot of ways. The previous speaker showed about plates. What we commonly, I think, most of us have been doing is a modified tension band wiring. You can use a tension band wire with a long IM screw also. There are 2 or 3 points which I would like to emphasize on. My preference is an olecranon osteotomy in the bare area for all intra-articular distal humerus fractures. If you are a good orthopedician, you should be able to do a good, properly modified tension band wire. And if you do that, there will not be any problem of union or non-union or other things. The tension band wire must be proximal to the K-wire exit. K-wire should exit in the anterior ulnar cortex. The wire or non-absorbable material should not be looped only around the bent K-wire. It should be taken through the triceps tendon for better healing. This is an example which I would like to show all these things, but here the wire is a little intramedullary, but this is what was done. And the future depends on what we do in the present. I would also like to take this opportunity to invite all of you for the forthcoming TNOA conference, annual conference at Erode. Thank you.